welcome to our community update this afternoon actually. I'm just going to wait a couple more minutes as people are still joining, so we'll wait a minute or so. And welcome. So please, as we are getting started, just a reminder, I think everybody's pretty adept with Zoom these days, but just a reminder that you can choose the view that you can see. So we are spotlighted at the moment. So I'm Clare Mullen from Health Consumers Council, and I have with me Dr. Andy Robertson, and we'll do proper introductions in a second. But if you want to see everybody on the screen, if you're on a computer, you can push the button at the top right of your Zoom screen that says view, and you can switch between gallery and speaker, even though we are spotlighted. We will be asking everybody to stay on mute during the session, just so that we can have a conversation without any background noise. We have got a whole list of questions that were submitted in advance, but please do feel free to use the chat as become commonplace. Feel free to introduce yourself, perhaps say where you are joining from, we will, I'm just going to check. Kieran, is there anyone else in the waiting room, or shall we make a start?
You're welcome to make a start. They'll just come in as they join.
Fantastic. Okay, well, welcome everybody. Thank you, Andy, for taking part in this conversation today.
That's all right.
As we get started, I'd just like to take a moment and acknowledge the traditional owners and custodians of the lands that we are variously meeting from. Where Andy and I put our feet on the ground, that's the Whadjuk people of the Noongar Nation. And I'd like to pay my respects to elders past, present and into the future. At Health Consumers Council, as an organisation that speaks up for, or advocates for people to have the right to have a say on issues that affect them, people won't be surprised to discover that I personally was saddened by the referendum result, but we continue to stand in solidarity with Aboriginal people, and we'll walk alongside and continue to champion opportunities for Aboriginal people to have a say on all things, but particularly health issues that affect them, and recognise that this always was and always will be Aboriginal land. So welcome to, I think this might be, I don't know, number 7 or 8 of our COVID community conversations that we've been having since back in the day of 2020. And Health Consumers Council is an independent organisation that was established to provide a voice for people who use health services and people in the community on all aspects of health. And one of the things that we value doing is creating opportunities where people in the community and health consumers can hear directly from WA health leaders. Many of you will know Dr. Andy Robertson. He's the WA Health Chief Health Officer, who was a very familiar face to many of us for many months in the early stages of COVID. And we thought we would provide this opportunity to give a chance for people in the community. We know that there has been media reports about this current wave of COVID. We also know that for many people, they don't feel that COVID has gone away. We do know that some people in the community may feel like that, but for many people, as evidenced by the questions that we've got submitted, don't feel, and we're very much living with COVID and adapting to COVID. We do know so like I say, please do use the chat. We've got the Health Consumers Council team on hand who are monitoring the chat. Our aim today, I know that this can be a subject that potentially people feel quite heightened about, and people have some real concerns, and we've captured many of them in the questions. But we do ask that we maintain a really productive and supportive environment in the chat. And so, like I say, the team will be monitoring that and sending any other questions that come through that that come to us. But like I say, we do have a big set of questions to get through. So thank you to those who submitted them in advance. So, Andy, over to you. I wonder, is there anything in general that you can tell us at the moment about this current wave?
So it might be good to sort of set the scene a little bit. So currently, as you may be aware, we put out a surveillance report every week that comes out on our website. So our latest surveillance usually comes out on a Wednesday, so the surveillance report looks back is a little bit old, but I will give you some updated figures. But we've So in the week up to the end of December 3rd, so we've had 501 COVID cases reported. Probably more critically, there were 54 new hospital admissions, and there was, at that stage, there was some increase compared to the previous week. But the 7-day average of the cases had decreased by 2%, and the intensive care unit had gone up slightly. If we look at this week, and I do have access to our current admissions and inpatients, it would appear that most of our hospitalisations peaked probably around the end of November.
Right.
So we've been tracking downwards for the last 2 weeks.
Right.
In hospitals, our admissions over the last 2 weeks have dropped from 126 a week to 92 per week.
Right.
And I will make the point that that's not all cases of COVID.
Yes.
That is people both who entered for COVID,
Right.
so they have severe disease, or entered for some other reason. They could have broken a leg or had a heart attack, but were discovered to have COVID when they entered. So it gives a bit of reflection of both how the seriousness of the disease, but also what's out in the community as well. So that had dropped down to 92, and similarly our inpatients had dropped from 189 down to 161. Right. Now it's still up, but again, not all of them are in hospital for COVID. And similarly in our ICU, a number of them are there. Predominantly, this remains EG5, which is known as EG5 is the subvariant. We're also looking at BA 2.86. So EG5 is known as Eris. BG 2.86 is known as Parola.
Okay.
We haven't. And this outbreak has been predominantly Eris EG5. Right. So that's what we're seeing in our wastewater, and that's what we're seeing in our genomic screening. People may be aware there is another, and there's been some reporting in the last 48 hours about a subvariant called JN1, and in the US it's now rapidly becoming the most dominant variant. This is a subvariant of the 2.86. Right. And we haven't seen it in WA as of yet, but certainly Victoria has, and they're describing it in their wastewater. Right. And it seems to be increasing. Again, it doesn't appear to produce more severe disease, but it's obviously has spread and is becoming a dominant strain. Right. Or has certainly in the US. Yeah. We do continue to monitor in our hospital. We do test people in our hospitals with PCR and rapid antigen testing. And a significant percentage of those go for whole genome sequencing. So we do track what the variants are, both within our hospital settings and outdoor, not just restricted to hospital, but also in our wastewater as well. Yeah.
And so when you talked about the weekly surveillance report, and you talk about 501 cases, there was a few questions, as you will have seen, about when previously people were required to report a positive PCR, or PCRs were being recorded and rats were required to be reported. So where is the surveillance information coming from now that that's no longer required?
So it's largely coming from PCR testing within hospitals. Within hospitals. Yeah. Some being done by GPs. People may present to their GP and request a test. So some of it is being done in the community, but it's being predominantly done in hospitals. Yeah.
And again, anecdotally, we pick up, so many of the rats, I think, have now come to their, many of the free rats have come to the end of their expiry date.
Yes.
But is there anything, you mentioned all the various subvariants, is there anything that people in the community need to know about with regards to, so for example, again, anecdotally, I hear the current strains don't respond to the rats in the same way that previous strains might have. How do people know to trust the rat?
the rapid antigen tests are pretty good.
Right.
However, a lot of people just do it on the first day.
Yeah.
And they really, I fall into the same category. I started to feel unwell. It's about 4 weeks ago now. On the Monday around lunchtime, felt a bit unwell at work. Decided that I did a rapid antigen test here at work. It was negative, but I just felt unwell, so I went home. And but the next day, symptoms hadn't improved at all, and I tested and I was strongly positive. So it's often, we can test slightly too early.
Right.
And so what we strongly recommend is if people are negative on the first day, that doesn't mean they're negative.
Yeah.
They need to consider doing a test the following day. And in most people find that they are positive. If they still really do have the symptoms and things like that, that they are positive on the following day. So you may need to do them a couple of times while you're symptomatic.
And so just a reminder then, in that scenario, had you, done the test and not perhaps been the chief health officer and said, you know what, I'm fine, I'm going to go about my business, you would have been infectious at that point.
Correct.
Yeah, and so therefore spreading it around.
Yeah, exactly. So, and this is the one of the strongest messages we try and get out is, if people are unwell, and even if, their rats are coming up negative, they should be staying at home and not going out. And it's not just to work, obviously that has a imposition, has an impact on your workplace, but also, and certainly that's critical within our health setting, but also a lot of this spread is occurring in social settings and family settings. That's where people are picking it up. I mean, interestingly, I think I picked it up at a social function at a medical conference. So there's certain irony there, but it is the reality. And people are and people go to these events. They feel a bit off, but they decide to go, and that's probably where most of our infections are coming from.
Yeah. So I guess I'm hearing, and I don't want to put words in your mouth, but the message is, if you feel unwell, test and stay isolated until you don't feel unwell, or you get a positive test. And if you have a positive rapid antigen test, then you really need to spend at least 5 days at home. Even if you're feeling wonderful after day 3. Right.
You're still potentially infectious. So we're still recommending 5 days. And in fact, it's longer for people still positive. For our hospitals, we recommend longer for that. Right. So what's the recommendation for hospitals? If they're negative on day 5, they can return to work the following day. If they're still positive on day 6, or they have no test on day 6, they can return to work on day 7. Yeah. Okay. Okay, so we might come back to a little bit of that, because as you saw, there's a lot of interest, and I don't think I was aware that there's a weekly report. So I think we'll make sure that we circulate information about where that weekly report is. There's a link. We can send you the link. Fantastic. It's an easy, as with websites, if you know where to look, it's easy to find, but we can provide a link. And encourage people to have a look at it, because it does, although the case numbers are obviously a lot less useful for predicting where we're at in the disease. Certainly the hospital numbers, whilst they are usually a bit behind, the hospital numbers are usually about a week behind the case numbers. So they do reflect the hospital. They give a better indication of where we're at on the, in the outbreak, whether we're still on the way up or on the way down again. So when we were talking before, we mentioned that vaccinations are, as they were in the earlier waves, the best protection. But I think there is still, perhaps at the moment, a bit of a lack of clarity about current vaccination advice. Now, I did check in with the health department, and if you look at the health department website at the moment, it may still have an old date on it, but I checked with the comms team, and that's not that the information hasn't been updated, it's just that the date hasn't been updated. So we are working with the comms team about them putting accurate dates when the information was last updated. But
What is the current advice for vaccines?
So the most recent advice, which has come out from ATAGI, and it builds on advice they put out in both February and in September. But this relates, as people will be aware, the new XBB 1.5 COVID-19 vaccine became available yesterday.
Right.
So it was launched yesterday. But
when you say launched, do you mean like internationally or in Australia?
In Australia. In Australia. Sorry, yeah. It has been available and in other countries.
Yeah.
I think in the US for a little while. And it may not be available in some other countries.
Right.
But it certainly has been, it certainly has become more available going forward.
Okay.
So the, sorry, I'm just going to grab a piece of paper. So the advice is a little complicated, and I went back to the original ATAGI advice, but largely what it's saying is if you're over 75, they recommend, and regardless of whether you've had a first dose this year, they recommend you have it.
Right.
So if you had a first dose earlier in the year, which is and you're now 6 months past that and you haven't had any infection, they recommend you have a second dose. If you are at risk, if you're 65 to 74, you're recommended to have at least one vaccination this year. So if you've already had that early in the year, then that is fine. They're not actually recommending you have it, but they do say you may want to consider it. So if you're 65 to 74, you had your first vaccine, say in March or April, you've gone 6 months, then they said you can consider having it. It's not strongly recommended because you will still get good protection from the previous vaccine. And that's regardless of whether you're at risk or have no risk factors, so 65 to 74. If you are 18 to 64, which is a fairly big age group, they're actually, they recommend you have had at least a first dose this year if you're at risk. If you're not at risk, it's a consider. And say they consider having a first dose. If you're at risk and you're 18 to 64, so you've got medical issues, particularly if you're severely immunocompromised, they recommend you consider having a second dose. And if you have no risk factors, they don't actually recommend 18 to 64-year-olds to have a second dose. So this dose, and then once you get to the 5 to 17-year-olds, they're only recommending the 5 to 17-year-olds if they're at risk, have one dose, and not recommending anybody else have a dose. So, and under 5, they're not recommending it. So that's an easy one. So it's largely focused on your immunocompromised, at risk from, and then those over 65 and particularly over 75. In summary, I know that's a bit. Difficult, and to pick up on your point, we will be putting up an update on our website that reflects all of this. So that was been part of the discussion in the last little while, because it is a bit difficult.
And so in terms of, for example, given that this question about whether or not somebody's at risk is a big factor, has there been any update to what at risk might mean?
So, there is, at risk is defined as including those with a medical condition that increases the risk of severe COVID-19 illness. So there is a link.
There is a link,
and that refers to the Australian Immunisation Handbook. or those with disability with significant or complex health needs or multiple comorbidities which increase the risk of poor outcomes from COVID-19. So,
but as far as you're away from the conversations, there hasn't been another group that might not know that they are at risk. It's the same.
The group hasn't changed.
Yeah.
If you were considered medically at risk before, throughout this discussion, or have moved into those groups, it hasn't changed. There may be some refinement over time, as some conditions that may not have been, either we've learned more information about over time, and I think that has occurred, but many of the particularly those people who are immunocompromised and the like, have continued to be.
And look, again, I know we've offered in the past, and if we can work with you to help make that advice as clear as possible, because obviously a large cohort of people that we work with do perhaps either are in that category or have in the past been told that they're in that category, be really helpful. I know when we've looked at the information on the health department's website, it's pretty generic, and so I think it would be really good, because we do know that even when consumers are going to their GPs that they might have worked with for a while, it's sometimes the consumer who's the expert and saying, have you heard about this? Can you help me with that? So if we, obviously our role is to try and make sure that consumers have as much information as in their hands as possible. So if we can help to tailor that and just flesh that out a little bit more. Fiona Stanley Hospital did a great job. They were one of the first off the ranks with regards to making sure that information was really, really clear for people. But if we can help, we'd love to.
And certainly hopefully we'll have that up later today. And obviously
if we see opportunities,
if you feel it needs further elaboration, I'm happy to look at that.
And so just in terms of, so you just outlined the recommendations. Let's say somebody wants to get a vaccine. Are those available free of charge? Do you need a script?
Look, the vaccines remain available. There's no requirement. The vaccines are provided by the Commonwealth Government, that they are free, and available through general practitioners and through our different groups. I was trying to think they are already out in a number of these areas. So they have rolled out, and they were rolling out last year, last week.
And so that information might also be on being updated.
It won't necessarily say which GP or which pharmacy, but certainly, the people should, talk to their local GP or their local pharmacy and see whether they are offering that vaccine. And if they are eligible, then certainly they should be considering getting it.
Great. Okay, so then if we move on to this issue, like I say, protections for medically vulnerable people, particularly in hospitals. So you saw that there was a fair number of questions that were submitted. People feel a concern. Now, obviously, it was mandated that masks be worn in some high-risk areas. We're hearing stories that that's not necessarily happening, and that consumers
should be happening.
Indeed, it should. Yes, and I guess what are the mechanisms for consumers being able to? So, as I've commented elsewhere, it can be hard, as you know, for consumers to assert their rights in healthcare settings because there's this power dynamic. And I know of at least one person who asked somebody to wear a mask because they themselves are at high risk, and they asked a health professional to wear a mask, and they wouldn't. So what mechanisms are there so that medically vulnerable people can feel confident that when they are in the areas where masks are mandated, that that's being monitored, and if it's not, what can we do about that?
Oh, look, you can certainly raise it with the hospital at that time, and it is very clear. I mean, when we mandated the masks in the high-risk areas, that was done in full agreement with all of the chief executives of all of the HSPs. It was very clear as to what those are. I mean, sometimes people think, oh, look, I'm high risk but I'm in a general ward. So, so it is obviously focused on areas that are, for example, oncology wards and things like that, where there is the most likelihood of having people who are at high risk. But we do appreciate that at times people may have some significant health issues, but maybe in other parts of the hospitals which aren't necessarily covered. But certainly, if it's in any of the high-risk areas, we haven't changed those recommendations. I have been asked to review them periodically, and we haven't changed them as of yet. Obviously, if, as we hope, we're now starting to track downwards, then obviously at some stage, I'm sure there will be a request for us to review them. But at this stage, we continue. So they should be asking, talking to the staff there and saying, our understanding is that masks are required in these high risk areas, and we're just wondering why that's not happening. And that's certainly something. And that's for visitors as well as for staff.
And in terms of, so we can certainly help people understand their rights in that area and provide some, mechanisms for people to flag with us if it's not happening, so that can be fed back to the hospitals. So is there a requirement, it's perhaps a difficult question to answer, but I'll ask it anyway. If a person who knows they're high risk because they have been at a high risk, they are in a hospital setting, but they're in a part of the hospital that's not in itself high risk, what's the stance on if that person asks for the staff member to wear a mask, which I have to say to me doesn't seem like a really big ask.
No.
Is there any guidance on?
Well, the
guidance also said they're recommended in our part of the hospital.
And that was deliberate.
Yes.
Because there was, as sometimes you have these discussions, but some of the hospitals would have liked us just to say encourage.
Yes.
We actually got agreement that would be recommend.
Right.
So it's a bit like the vaccinations. It's a bit more than we just encourage people to do it. We are actually recommending. So look, I think it is not unreasonable to ask that question. It is recommended, and obviously if somebody's at high risk and they feel that they're in a bit of a vulnerable position, then I think it's perfectly reasonable to request people put on a mask. And we're not asking them to put on a.
That's right. We're not talking about full hazmat.
A full hazmat.
No, yes.
It's putting a surgical mask on. And we know that will have an impact on the disease spread.
Because I was going to ask about surgical masks versus respirators. Am I pronouncing that right?
It's a P2N95 respirators or the masks. Look, some areas will recommend the use of N95 P2s. That's up to the hospital to specify which areas, but some areas will make it a condition of entry to those areas. I will make the point though that they, as masks, they are quite difficult to wear.
Yes.
They have to be appropriately fitted. I couldn't wear one with a beard, so for example, and some people, because of the shape of their face, have difficulty getting good seals. And without a reasonable seal, they're not actually that much use.
Right.
They're actually not much better than and if people don't wear them properly and they're sort of, not well fitted, then you're better to have a well-fitted surgical mask than a poorly fitted N95. Having said that, obviously in areas where they are critical, people do fit them well, they are worn appropriately, but they're not without their problems. People end up with quite significant, can end up with quite significant rashes and everything. So, obviously people are not keen to wear them unless they feel it is critical for the patient.
But surgical masks do offer protection.
They do. For both, they do offer protections, and that's why we ask visitors as well to wear them. Because to be honest, quite a lot of the infections come in either with the patient or through visitors,
Yes.
and as well as potentially staff.
So that going back to the question about vulnerable patients or people who are medically vulnerable, and like I say, many protections having been listed, and we know generally in the general population there's varying degrees of support, let's say, for protections. And I have to say, many of the comments that we've had through this event and a separate survey that we did express a fair bit of concern from people, saying it's as if people think it's gone, think COVID has moved on, and don't have a full understanding of the risks to some people, particularly people who are medically vulnerable, like we just talked about there. One of the areas, for example, is people finding it hard to sustain work and social lives. You know, there's a kind of general belief it's kind of over, but that message about COVID being airborne and encouraging better use of air quality and making sure, you know, suggest meetings outdoors, have windows open, let fresh air and those sorts of things. Do you think that those messages is there any plans to strengthen those messages about creating conditions that are as healthy as possible for as many people as possible?
Look, I think, well, I think there's two aspects to this. One is within the hospital. So we already have our infection control guidelines, and they do make it very clear about obviously the risk from aerosols, as well as from other methods of transmission, and the use of improving ventilation, and ultimately of HEPA filters in certain areas where, for whatever reason, they can't get the appropriate ventilation through those areas, and that's played out, and that's, I think, been quite well established over the last 2 or 3 years now. In the broader community, look, it is a lot more difficult, and yes, there's a lot of complacency out there, but I think most people, and particularly, most of the population, or very, have had the disease. It's been relatively mild, and they may not, unless they have somebody in the family or have an elderly relative who's had more severe disease, they may not really appreciate that that we are going to continue to see waves of this disease, and that unfortunately it will continue to impact on those, the elderly and those most at risk, despite the fact that they may well be vaccinated. And obviously, a lot of our push has to continue to be on vaccination, because we know that it really does help prevent severe disease, and we continue to see that those people who haven't been vaccinated are disproportionately represented in our serious disease and death figures. Can we, we can encourage people, and certainly we encourage people who are medically vulnerable to, if they are out and about, to obviously consider wearing masks, including N95 masks. That will help them, and the N95s, if they are appropriately fitted. But there is no, other than encouraging people to not go shopping when they're coughing and spluttering, or not go to a social event when they've got the disease. There are limitations on what we can do, other than putting out good public health messaging about why you should be staying at home, what some of the measures you can take. Because, I mean, I've been part of conversations, and we've talked about it briefly before we started, the conversation about how it's almost as if, COVID has become another factor of disability. There are people whose lives were very different before COVID, in terms of, because they're now in these categories that you outlined before, they are now not socialising in the same way, not necessarily working in the same way. And one factor that's been raised is, for example, people travelling overseas who are at greater risk, if they're going to be going to a country or going to be away from their general practitioner, is whether or not they can get access, for example, to antivirals that they could take with them. I guess, to me, as a layperson, I sort of think about it as a little bit like an EpiPen. You carry it in case you need it. Do you think that kind of thing might become possible? Look, I think it's a good point, and and certainly in the travel medicine space, there are a number of medications. I mean, if you're going to parts of the world where the health systems are not as robust, you may, and where things like gastroenteritis are more common, you certainly, it's often good practice to take a diarrheal kit, which may include antibiotics, for example. So look, I think that's certainly something that can be looked at going forward. But again, a lot of it is around good prevention. And I, having flown to the East Coast a couple of times in the last few weeks, it is interesting to see how many people are still wearing masks on planes. A lot more than certainly, if I go back 4 years.
Yes.
There's still, quite a significant proportion, generally older, but older people, or obviously people who may have other health issues that they're trying to prevent.
Certainly, I've had the chance to fly a couple of times this year, and I've worn a mask every time because being a little bit heightened around this. So just then to go back, there was a question from Michelle just clarifying. Could you just clarify again this issue of the respirator, if it's not perfectly fitted, over a surgical mask? Or how much of a difference is a respirator that's not fit tested?
It's hard to quantify. Right. I mean, it's not an exact science, but because it depends a little bit on how. If it's pretty well fitted and you've got a reasonable seal, then obviously that's going to be better than probably a surgical mask. But if it's poorly fitted, you're getting a lot of air coming in and out of the sides. Or if you've got a beard, or your face doesn't seal because of the how your face is structured, doesn't seal particularly well, and you're getting a lot of flow around it, then a surgical mask that is tied around will give at least equivalent protection. So and often people find it far easier to wear surgical masks. They're quite adept at doing that now. And if it's well fitted, and then any surgical mask that's poorly fitted is obviously pretty much useless, and cloth masks are a little limited. Maybe have some fashion utility, but not too much in the way of protection. So
surgical masks, but not cloth masks.
Cloth masks.
Limited
they have some limited protection, and they're not zero, but they're and they certainly. I'd rather somebody put a cloth mask if they are actually coughing and spluttering. I'd rather they cough and splutter into the coffin. As a point control, in the sense of you're controlling them spreading. Yes, they do have some benefits. They probably have less benefit if you were trying. If you're trying to avoid getting and trying to protect yourself.
So moving now then on to, there was a fair few questions around, if you like, an interest in switching the focus or extending the focus away from the, I get COVID and what that's like in the moment, over the moving a focus to the long-term impact of COVID, either perhaps long COVID as it's known, but also potentially the impact of having multiple infections. Is there anything that you can tell us that's new about that?
Look, I think as the medical research has continued, and obviously we've seen the ongoing progression and the waves, what we have seen is that I suppose two things. One is, and it probably is part of this. The key message is the more times you get it, the more likelihood you are to have some form of complication. Now that could be long COVID, or it could be something. It could be one of the other impacts, particularly on heart, lungs, your neurological system, and on various blood systems. So people talk about pericarditis, for example. This is a risk with vaccines, and there is a small increased risk of pericarditis and myocarditis in vaccines, and that's well reported. What isn't as well reported is that the risk of getting either of those conditions is a is a step, another 10 times that or more if you actually get the disease.
Right. Okay.
So, and the more often you get it, the more likelihood a number of these conditions are.
Yeah. Yeah.
So you may end up having, cardiac issues. You're more likely to have cardiac issues. You're more likely to have some of the other complications, lung complications, some neurological complications. So minimising your exposure to this disease is important. So we're all probably going to get it, but having it once, I've had it once in 4 years, and I'm in no hurry to get it again, and that's what we should be doing. And part of that is, again, encouraging staff, encouraging friends, encouraging family. If you're sick, stay at home. Do us all a favour.
Yeah.
Long COVID's interesting. Obviously, there's a paper coming out in the Medical Journal of Australia shortly, and there was a bit of a reference to it on Sunday in Sunday's paper, that some of our people here in communicable disease control have been working on, and they've been looking at long COVID and what might happen. But one of the key findings was that the more vaccines that people had, the lower the chance of getting COVID, long COVID.
Right.
So if you'd have done all the right things and you've had your 4 or 5 or whatever's recommended for your particular age group, 5 or 6 in some cases, there was a lot lower risk of developing long COVID. So it is protective.
Right.
It appears that the vaccine is protective. It's not completely protective, but it is protective. So, and certainly when you compare it to, those who are unvaccinated, they're a lot more likely. But unfortunately, what we did find was obviously that, they also looked at Omicron, and it still does appear to give the same risk. So again, trying to avoid it remains one of the critical things to the degree you can. And I appreciate that's difficult in a society that's largely not wearing masks.
Although the reason I asked the questions in that order, because we've got some questions about COVID messaging, is because I do feel that this point about that COVID's long-term impacts are still potentially serious for the general population.
Oh, they are.
Is a potential lever for better health protections for us all. But to stay with long COVID just for a minute, is there anything you can tell us about WA Health's availability of long COVID clinics? So
a lot of the focus on long COVID is now focused with a lot of the care is being delivered by primary care. So we have had a clinic in Bentley, but you'll probably be aware in most states the dedicated clinics are closing. Because what they're finding is that either the issue may be long COVID, and a lot of this is being managed by our general practitioners, or it may be the other complications you can get, and they really need specialist care. So if you've got myocarditis as a result of your COVID, then you need to be seeing a cardiologist. Or if you've got neurological issues, you need to be seeing an appropriate specialist in that area. So it is important, and look, and I think this still is an evolving area, and it may be that there remains, a need for ongoing clinics in this space, but a lot of it is being now managed by general practice.
And I do know that at some point there was a conversation, for example, about treating long COVID as a chronic condition, meaning that if you, and I know this is outside the remit of the state health, but if, for example, with in primary care, if you could get access to, for example, a GP management plan, but the definition of a chronic condition being that you've already had it for a certain amount of time, as opposed to it's clear that you've got some symptoms that could very much develop into long COVID. Let's get early intervention and support you as early as possible. Are any of those conversations happening about what people should be looking out for in long COVID?
Well, and the good thing about long COVID is that it's more a focus on how long people have it for.
Right.
And what we see over time is that it actually decreases.
Right.
So long COVID doesn't tend to be a percentage, it tends to decrease over time. So the number of people who still have significant symptoms at 3 months and then at 6 months and then 12 months. It's not to say there won't be a percentage who still have a 12 or 24 months, but it is going down. So, over time, a lot of these symptoms do resolve. Yeah. There were a couple of other things from their studies. So they found it's 50%, the risk of developing it appears to be higher in women. Right. 50% higher in women. It increased, the chance of having it increased with age. So individuals aged from 50 to 69-year-old, for example, were more than 50% more likely to develop long COVID than 18 to 29-year-olds. That it was higher in people who have an pre-existing health condition, 50% higher. So if you've already got a health issue, and the chances were that it would be. And it was inversely related to the number of COVID vaccines. So if you had more COVID vaccines you had, the less likely you would to get it.
So what we can potentially be taken away from that a little bit is access to vaccinations, access to up-to-date information about vaccinations. And then again, if I can go on to the messaging a little bit in terms of, and there's been a question, I guess, a bit of the messaging about COVID in education settings. So obviously schools, are sometimes hotbeds of all sorts of infections.
Oh, they are. And obviously that's an interesting population because they are, they often have very mild disease, and they're not particularly compliant. So we have been working, and we've worked for quite a long time with education on improving ventilation in the schools, opening that up, making sure there is good ventilation, including the use of HEPA filters where appropriate. So that sort of protocols have been in place for some time, and they did quite a lot of work in looking at the schools. Again, a lot of the messaging has to be around, if your kid's unwell, don't send them to school. Yeah. And unfortunately, that's not a message that always gets through, or, oh yeah, Johnny's fine after 2 or 3 days. Let's get him off to school because, we can't get anybody to look after Johnny. And I appreciate that's a struggle, but that's where a lot of it comes from. The other side of it is that a lot of it may not be actually spread in schools. But Johnny's off because he's got COVID, but he then goes to football practice. Right. Okay. Or he goes to, he goes out to meet some friends down at the local shopping centre or whatever. There are those social, sporting, family events often just are as relevant in the spread as school is.
So then go to the messaging, because there's a comment come through about that some of the schools have the filters but maybe aren't using them, is how do we get across to the pop? And I realise that this perhaps falls into the category of behaviour change and social marketing, but from your perspective with other public health campaigns, how can either the consumers themselves or what can the government be doing to, I think, potentially draw on this health impacts of long COVID and the health impacts of multiple infections? What opportunities are there that we can use to use those messages to reiterate, get vaccinated, stay well, stay away, isolate if unwell? Like, how can we keep getting this across that this hasn't gone away?
Yeah, look, eventually this will probably will become more like our other respiratory viruses. Right. That, and we will have a seasonality to it. Now, we haven't seen that yet. We're still getting, as we've had this outbreak now, and we obviously do the winter season type messaging quite strongly, and that could be flu, it could be paraflu, it could be RSV. We do put out strong messaging about the kind of things that we can that you need to protect it. So it will get incorporated that in due course. However, we're probably still in this stage where we're still getting these outbreaks. The other challenge we have with this particular disease is obviously it's not flu, so it does behave, it mutates quite often, and we could potentially get more disease. So we will continue, and we periodically do messaging. We did quite a bit of messaging around when we brought masks back into the hospital. So we do use opportunities, but
bear with us. We are just going to see. We hope we're not about to lose you, but there was a message on screen about the system shutting down.
It means we've been on the system for about an hour.
Right. Okay.
For some reason,
that's enough.
It reckons that after an hour, you can't still be talking. So look, and so I think we just have to use the opportunities, and and we appreciate that through Health Consumers Council and other venues that we continue to keep this message going. But to be honest, I'm not getting asked requests to do lots of media anymore, or there are not a lot of things. So we have to use whatever opportunities we can to keep pushing those messages. So at Levers, we use that as an opportunity to say, look, one of the things at Levers is, if you're unwell, don't go on to Levers. Don't infect all your mates at Levers. So we have to continue utilising those opportunities.
And I think what I'm taking away from this is how we can support with more messaging for our audiences, drawing on. So what we do know too from a survey that we did, it was a small number, but really strong focus people are using government websites as their source of information. So I think if we can work with you for us to keep helping make sure that message is refreshed, because I think this question around the research is still evolving, and there's been a couple of comments in the chat about, for example, you're saying it might become seasonal, but it hasn't yet, and that while we talk about it as a respiratory condition, actually it's obviously the effects of it has effects on lots of different organs.
Yeah, that's right. The effects of it acts to a degree like a respiratory virus in the sense of its transmission through aerosols and droplets. But it's a very different virus than influenza, and so has other impacts that are not seasonal. But and that's why we do have to treat it. It's despite some of the commentary which is around, it's just another flu. It's not. We know that. It's quite a different virus. It's got some quite significant impacts in different groups, including sort of serious disease and death. And we just have to, as we do. I mean, we also take flu very seriously because we know it impacts very much particularly the under 5s. This doesn't, but and the over 65s. This, we do know that these diseases do target specific populations, and we need to be very cognizant of what that means.
And I guess then, in terms of other avenues for getting those messages out, do you see over time it could become something that's strengthened, for example, in workplace health and safety messaging around, I know at Health Consumers Council early on we opted to invest in good quality air filters because we know that there will be a number of people who come to our site that may be at high risk. So we wanted to create the safest environment, but they're not cheap. For a small organisation like ours, it is an investment. But is there anything like planned potentially to sort of strengthen the messages through?
Look, I think with the WHS will be a key message, a key aspect going forward and I appreciate the the new legislation is relatively still being implemented, but I think as they look at it, I think that is an area where there will be questions about, are we protecting our staff appropriately, and that includes obviously any visitors to our to our work sites, wherever that may be. Are we protecting them appropriately? Is there more that we can be doing? Not just about COVID, you know, against any respiratory virus, or for that matter, any disease that is communicable.
So look, we are almost at time. Thank you so much for making this time available. And now that we know that you're not getting a lot of media requests, we might come back to you from time to time and ask for you for your input, so that we can keep giving people, because I think that's the other thing is, again, as a community, we heard about it every day for months, and then and I understand why, when we opened the borders, it was a bit of a sharp turn, you know, in terms of we shut down the state yesterday, but today, you know, we're going to go about business, get vaccinated and everything else. I think there was a strong interest from people about current information and regular information from government sources as a source of truth. So thank you very much for making yourself available. Is there any final comment you would like to make as we close?
Look, I think the one final comment is that a lot of the general messages have remained the same. And we really just need to keep reinforcing them. That, you know, the public health messaging has been appropriate all along, and whether that's, you know, not going to work, washing people's hands, you know, people washing their hands, whether it's the general messaging around people getting vaccinated if eligible, remain constant. And while I still get, you know, commentary from people about, you know, stopping the vaccines and things like that, we know that they've been highly effective in, you know, and we just, as were our border closures, you know, we just look at our overall mortality figures were, you know, half of any other state, and that's largely due to a population that did the hard yards along with borders, public health measures, and the vaccinations, and I think that's actually been highly effective. And
that prompts me, we could have a whole other conversation, that prompts me, maybe we'll see if we can get something in the new year around, as we were talking at the time, you know, we're starting to see conversations about the impacts of some of those health measures, and you know, on young people, and the impact on young people who, not just in WA, you know, internationally, weren't able to go to school, and all of the effects and that kind of thing. I think that's a whole other scene.
And we were highly effective. I mean, we actually, most, you know, people that went to school, and I think we do have to, you know, fortunately we were able to prevent disease in our broader community, so we could keep kids at school, and that. I think most of the research coming out now is showing that that's a good thing. The ones that really have suffered are the ones who weren't able to go to school for, and sometimes they were very good reasons why they couldn't. But it is a consideration when we're looking at planning in the future.
And that's always the thing, isn't it? I guess in the area of public health, is you're weighing up a whole number of factors at the same time to make these big decisions for the state. So thank you for your time today, Andy. Thank you very much, everyone. I know there's been a lot of chat. I can see 86 comments in the chat, although we haven't been able to monitor them here in the room, but the team were. So thank you very much for your time and interest. I think the team, if we haven't already put something in the chat as an evaluation form, then we'll send one out afterwards. We do still have our COVID survey open. So we'll circulate that too, and please do let us know. I think I'll be chatting with the team about how we can support people, particularly on this issue of masks in hospitals, that how we can support people just to understand their rights and support you to assert them. So thank you very much, everyone, for your time today. Thank you, Andy. And now we'll do the Zoom wave. Thanks, everyone.